And to some extent that has to do with, requirements and restrictions by the FDA. And the FDA does a lot of things to keep people safe, which is
Mhm.
great. But sometimes that can be at the expense of innovation. But sometimes because of that pipeline,
Mhm.
you understand what disease is, but you don't really understand what healthy is. You
Mhm.
define healthy as the absence of disease.
Yeah.
In my opinion, that is not a good enough definition. Well, like I finished therapy, can I go back to sport? And it's
Mhm.
like, well, sometimes, but there's a huge gap in that
Yeah.
part where we go from, okay, maybe we've rehabilitated from a pain perspective, and maybe
Mhm.
we've had some time to get some better tissue laid
Yeah.
down,
Yeah.
but it's not the same thing as being optimized for movement and human performance.
Yeah.
And that is a huge gap in the physical medicine system, musculoskeletal system of care.
Yeah.
And that's where I'm like, hey, like, I'm really happy that you did your rehab, but you really need to see a great
Mhm.
human performance, personal trainer,
Yeah.
biomechanics expert, et cetera. Like insert your,
Yeah.
your expert there, right?
All right, so we are here today with Dr. Trevor Turner, who is a phenomenal resource when it comes to all things regenerative medicine. Just very briefly about his background, he has a personalized, just plethora of research backgrounds. He has a medical degree from the University of Texas Southwestern, has done a surgical internship at UCSF. And realistically, I mean, I could go on a laundry list. There are about 15 different things that our research team put together. But what I would really love, Dr. Turner, is if you spent a second and gave people the pertinent things that you think really establish your identity as a professional.
Thanks for that that humbling intro, Andrew. So, yeah, I'm basically just consider myself very fortunate to have worked with a lot of great people from a lot of different fields.
Mm-hmm.
Medicine's very much like what we would consider the ultimate team sport,
Mm-hmm.
because especially in physical medicine, human
Mm-hmm.
performance, whatever you want to call it. There's no way that I can do my job as effectively without the other
Yeah.
people on the team. So I had the privilege to go work with a very famous orthopedic surgeon. James
Mm-hmm.
Andrews was his name. And he invented a lot of the techniques, frankly, that are used in orthopedics today.
Yeah.
What was also cool about being there is next door to our clinic and operating room, Exos Performance had a
Mm-hmm.
combine training facility. So we would get to be the physicians for the guys that were training for the NFL draft. We also had a grant program where if you were a special operations personnel and you got injured, you
Mm-hmm.
could come train on a government grant for a month or two with all the same resources.
Wow.
So the really cool thing about working there was, yeah, we had doctors, but like every one of these patients,
Mm-hmm.
I call them patients, would have a human performance engineer and would
Mm-hmm.
have a masseuse and would have a physical therapist and would have a nutritionist and would have basically this very comprehensive team built out.
Mm-hmm.
And so what I got to see is what really truly elite level healthcare was like.
Mm-hmm.
And what I think, unfortunately, in the medical system, we train to take care of really sick people,
Mm-hmm.
which of course you want physicians to be trained to deal with stressful situations of people that are very sick. But sometimes because of that pipeline,
Mm-hmm.
you understand what disease is, but you don't really understand what healthy is.
Mm-hmm.
You define healthy as the absence of disease.
Yeah.
In my opinion, that is not a good enough definition. I'm also, or used to be, I guess, excuse me, a CrossFit coach, which I realize will suddenly make some people like me and make some people hate me. But one of the things that I loved about CrossFit, there was a speech that Greg Glassman gave long time ago in one of the early CrossFit journals. And he was talking about this continuum. And so he
Mm-hmm.
talked about this continuum of sickness to wellness to fitness, right?
Mm-hmm.
And most people that are competing, they're always looking to be better than they were the year before. So
Mm-hmm.
maybe I set my PR last year, but I can be a second faster this
Yeah.
coming year. I can lift a little bit more weight, or I can be faster off the block, or whatever it is.
Mm-hmm.
So I tend to think about health the same way. And so instead of just being like, okay, well, your cholesterol's this, or your
Yeah.
your liver enzymes are less than 40, so that's great. It's like, well, why can't it be lower? Or why can't you have a better VO2 max? And so
Mm-hmm.
I think, in traditional medicine, we don't, the biomarkers maybe that we use, or the metrics that we use to define what's healthy and what's sick, is very different than what you'd use in the human performance space, whether you're amateur athlete,
Mhm.
collegiate, Olympic, pro, semi-pro, whatever it may be. So I felt very grateful to have that experience. And, at the same time, we had people in our community that was down. So the Andrews Institute's down in Pensacola, Florida, that didn't have a lot of resources. And
Mm.
so we had this duality between we have like the most elite healthcare team based approach ever. And then
Mhm.
we had a lot of people in the community that were like, that's great, but my insurance doesn't cover that, or I can't afford that, or what can I do? And it was very hard, like ethically, to be like, well, here's the best and here's the quote standard of care, which was
Mhm.
oftentimes not great, right? And so part of the reason myself and my business partner at Provita Health created the entity that we have here is we tried to make that elite level team-based health approach available to everybody,
Mhm.
right? Where you're integrating these different techniques together to really optimize health. And
Yeah.
most of the concepts in sports medicine translate pretty well to that when it comes to
Mhm.
metabolic health and reducing risks of chronic disease. And some of the patients I see are like people who just want to be able to play with their grandkids. And then we have patients who are like, hey, like I'm trying to medal at Kona this year, and I'm like, awesome. Right.
Yeah.
So we scale and modify things appropriate to the patient's goals.
Mhm.
Um, but we try to do it with a great team because I realize that if I'm the only cook in the kitchen, usually we're never going to get to the end goal that the patient has.
Yeah. Well, and I think it's really interesting when you consider, and you mentioned this earlier, the distinction between chasing a performance oriented, some kind of outcome. We know that that's very important from a goal setting perspective in psychology, versus avoiding disease. And so when we look at the bridge of like how healthcare is currently structured, there's a conversation I want to explore before we get into the main items here, which are really a lot of the regenerative techniques that are emerging today that coaches should know about. But when we talk about scope creep, and you mentioned like a standard of care, I think it's really important that we take a second to kind of establish what those things are for
Okay.
people to understand when should they start to look for additional assistance from a medical provider, outside of like maybe a pre-disease, like pre-diabetes is something that often comes up of people's fasting glucose maybe being in the high 90s, not quite to the degree where it would
Great
be.
example.
And so, in your experience, when you're working with, these personal trainers, these nutrition coaches that are referring you business and taking care of, your patients, and then you're helping them take care of their clients, I think that that clinical collaboration is such a missing cornerstone. And I love that you guys are pioneering that here. What would you say to coaches that may have a jaded view of the medical system right now of a sick care model versus a wellness?
Yeah, I mean, I think, you've seen coaches get more embraced now in traditional clinical models, and it
Mm,
depends what, I guess, kind of coach you are. But there was a
mm-hmm,
guy when I took a Harvard business class who launched a large venture called Iora Health, IORA. And I think he's had like either 7 or 8 rounds of funding, so many,
yeah,
many millions of dollars. And he was working with the Medicare Advantage population, which is a little bit different than the
sure.
population we see. But in his integrated care model, like coaches were a huge part of the
Mm,
ability to deliver care in a way that was meaningful and communicated to those patients,
mm-hmm,
and also to accomplish goals outside of a traditional, like, okay, I wore my white coat and I took your blood pressure today
yeah,
kind of encounter, right?
mm-hmm,
So I think medical practitioners are embracing it. I think where you see
yeah.
more people embracing it is when they're leaving the insurance market, right? And they're saying,
Mm,
this is a cash offering, and we put this cash
mm,
offering together
yeah.
because it includes the value of the coach's time
Uh-huh.
combined with the value of the physician's time.
Yeah.
And the reason that we do it this way is because we get the best outcomes.
Mhm.
And if you want the best outcomes, you're going to
Mhm.
come engage with us. And
Yeah.
if you don't or you're not willing, then you'll settle for the quote standard, right?
Mhm.
And I think some people hear that or think about that and they're like, "Oh, well, you're just treating a bunch of rich people and you're not taking care of the rest of the population." To which I say, "Listen, that is certainly not the case.
Mhm.
We see people who are servers from restaurants. We see
Mhm.
people who are maybe they're entrepreneurs of small companies and they don't have a big corporate insurance policy to rely on, right?
Yeah.
But we can create things with enough value for people that we say, listen, like you're basically paying cash anyways if you
Mhm.
have a $10,000 deductible, unless you get an organ transplant or something,
Yeah.
right? So most people in a lot of ways are paying cash for healthcare. It's just a matter of how much value we can pass on to the patient, right? And I think there's a way to run an organization where you're like, oh, well, it's 20 grand a year for everybody. That's clearly not feasible for most people.
Yeah.
But like for us, like we integrate with a human performance coach here,
Mm-hmm.
and we have some other options with PT and Cairo, but
Yeah.
like our baseline membership starts around 199,
Mm-hmm.
and that's feasible for a lot of people,
Mm-hmm.
right? Especially when they come and in their first appointment they have advanced blood work they don't usually get. They do a
Mm-hmm.
VO2 max test, they do a DEXA scan,
Yeah.
and if depending on how deep they want to go down the rabbit hole, we're
Mm-hmm.
using wearable analysis data. So like when you mentioned,
Mm-hmm.
your blood glucose is 90, we prescribe CGMs, continuous glucose monitors, for a lot of people that are not diabetic and even when they're not pre-diabetic,
Mm-hmm.
because we want to optimize the way that they fuel and the way that they
Yeah.
eat in a 30 or 40 or 50-year time horizon, and not well, we just want to keep you healthy, this year until we get to your next appointment next year, your next
Mm-hmm.
wellness appointment, right?
Yeah. So here's a hot topic then of this might be bait. Insurance is a scam, true or false? No, I'm kidding. Don't answer that. We don't want you to end up like the United Healthcare guy.
Yeah.
But
I don't think I'm on anybody's radar, but
yeah. But there's a question really around the accessibility and like being clinically indicated. And so kind of going back to when someone should potentially consider referring out to, when is something subclinical and when does that start to breach that threshold of clinically indicated where they should now potentially go and see somebody? We see this a lot of times with injuries. We'll see like a client comes in, their knee's bugging them a little bit. The personal trainer might be like, hey, not a big deal. We'll do this hip stuff. We'll do this foot stuff, this ankle complex.
yeah.
Sometimes it resolves itself. Sometimes it doesn't. In your experience, when would you encourage a health coach or a personal trainer or someone that works in that space to seek out someone such as yourself?
Well, I love to see people from the beginning. And
Yep.
I think part of that is, in sports medicine, you see much more acute problems than you would if you did
Mm-hmm.
chronic pain all the time, for example.
Yep.
But then, like case in point, like we had a patient yesterday
Mm-hmm.
who's 46, very high performing
Mm-hmm.
person, like very successful, very athletic.
Mm-hmm.
She's going to run the New York Marathon in a few weeks. And she had seen a PT who I haven't met her yet, but I want to because she sounds very smart. And they had a conversation about, well, maybe you should do peptides, maybe not. And I had my business partner called me and said, hey, I know this woman, she's seeing a great PT.
Yeah.
Could you work around and see her? And I said, yeah, we'd love to. So she came in the clinic and I noticed immediately that she had plantar flexion weakness on the left side.
Mm-hmm.
When you isolated to one leg before I even touched her or examined her. And so I was
Yeah.
like, okay, there's probably some structural disease here, right?
Yeah.
And we do a lot of diagnostic ultrasound here. So that's great because typically we diagnose immediately.
Yeah.
And a lot of times we eliminate the need for MRI. Not always, but
Sure.
oftentimes, which again passes value on to the customer, the patient client, which is great.
Mm-hmm.
So, and we measured her Achilles from right to left. Right was her asymptomatic side. It was about 15 millimeters at the maximum diameter. On the left side, it was 90, right?
Oh, wow.
So we saw a huge amount of hypoechoic signal, which is consistent with Achilles tendinopathy, not the same thing as a tear. But then, because we saw her, we started
Mhm.
prescribing some other treatments, some of which I think we're going to maybe talk about,
Yep.
photobiomodulation and laser.
Yeah.
But at least now we know exactly what we're working with,
Sure.
and we can be smart about the way that the PT also helps to approach her care.
Mm-hmm.
So like, I love seeing those people at the beginning.
Yeah.
To what extent we get to do that, it's really fun. Sometimes it's less fun when I see the patient who I'm their
Yeah.
third opinion and they've had 2 botched surgeries and then they're having a hard time restoring their function.
Yeah.
Of course, we're going to see complex cases because if you do a good job, people are
Mhm.
going to send you hard cases. But yeah, I loved being
Mm-hmm.
involved early and often. And then, I feel confident to
Mhm.
usually say, whether or not you're getting biodex testing and fancy isometrics,
Yeah.
we can usually examine you and we can take pictures with the ultrasound
Mm-hmm.
and we can see whether you have deficits.
Yeah.
And we had, there's a very high profile case when I was at Andrews, famous quarterback, RG3, came in. He had torn his ACL earlier that season, playing for the Washington Commanders. He was their franchise quarterback that they drafted. And my partner, James Andrews, had repaired his ACL, did a fantastic job with the repair. Great graft, beautiful looking surgery.
Mm-hmm.
And if you look at videos of him before he went back,
Mm-hmm.
6 months after his ACL repair, his movement patterns were just not there.
Mm.
Like he was not ready to go back yet.
Yeah.
He ended up, NFL is a complex beast, but he ended up going back too early, and then he
Mm-hmm.
got hurt, and ultimately he never, went on to play quarterback for a long time, which I
Mm-hmm.
think everybody hoped he would. He
Yeah.
was very good. So recognizing those cases and also understanding for me, like if I do a procedure and you go do your PT, let's say you're going to do therapy and then,
Mm-hmm.
your therapy benefit is up,
Yeah.
right? And so then it's like, oh, okay, well, like I finished therapy, can I go back to sport? And it's
Mm-hmm.
like, well, sometimes, but there's a huge gap in that
Yeah.
part where we go from, okay, maybe we've rehabilitated from a pain perspective, and
Mm-hmm.
maybe we've had some time to get some better tissue laid
Yeah.
down,
Yeah.
but it's not the same thing as being optimized for movement and human performance.
Yeah.
And that is a huge gap in the physical medicine system, musculoskeletal system of care.
Yeah.
And that's where I'm like, hey, like, I'm really happy that you did your rehab, but you really need to see a great
Mm-hmm.
human performance, personal trainer,
Yeah.
biomechanics expert, et cetera. Like insert your,
Yeah.
your expert there, right? And
Yeah.
so we try to create or facilitate networks of those people.
Mhm.
And, we learn pretty quickly who the great communicators are,
Yeah.
and who helps people have good outcomes. Because especially if
Mhm.
I send somebody somewhere else,
Mm-hmm.
it's my reputation on the
100%.
line when they say, well, they don't have a good experience. Like, why'd you send me to that person?
Yeah.
So.
Well, and I think that really, this is an aside, and I think a lot of people just establishing that network is a sign of professional maturity. Of I'm trying to do everything, and kind of revisiting, some of the question of how do we know when someone should refer out or when they shouldn't. I think it's a prophylactic. I think they should always be looking for those clinical partners that, hey, listen, this person had something in the initial screening or the assessment. Would love to partner with you on their care program. What does that look like? And much to your point, when we look at physical therapists that, work with an ACL replacement or some kind of knee injury, and they can isometrically load it, they can kind of do some knee extensions, but that doesn't translate to high force production when they're now having to sprint multiple functions of, G force on that joint when they just had to do it in a pretty controlled setting. So I think that's an incredible thing to hear, that someone in the medical side of the house is looking at it from that perspective. Because frankly, there is a conversation that's happening right now in the coaching space, and it's kind of been a little bit in the last 5 years or so, where now coaches are starting to disparage some medical providers of like, oh, they're just going to help you get off, they're going to put you on more meds, they're going to treat the symptoms, not the root causes. So we see this whole emergence of these like health hacking types of coaches.
Mm-hmm.
Terrifying for me, because I think that the thing that they're missing is the clinical skill of differential diagnosis, ruling things out, making sure that you're actually understanding anatomy, physiology to the degree that you're able to truly understand or narrow down what the precipitating incident, what some of the triggers are, so on and so forth. Which then leads me into, like, obviously being a physical medicine and rehabilitation physician, like, what if people are looking for different types of physicians, potentially, maybe they're not in the Atlanta area, which obviously Provita Health is currently in Atlanta. And if you haven't been here, you probably should, but for people that are looking, maybe they're in California, maybe they're somewhere else. Like, what are some of the hallmarks of a personal trainer should look for these things, or a nutrition coach, or what have you, when they're looking for that?
Great question. So I have a cousin who lives outside LA. Well,
Mm-hmm.
in LA, it's hard to tell if it's inside or outside,
Yeah.
but it's a big place.
So many cities.
And so he had a problem that I frequently treat, and that is radiculopathy, or, in layman's terms, kind of sciatica. It was really bad, to the point that, he was basically either going to have surgery or not. He'd failed some steroid injections. He'd failed a bunch of PT. He was like a young guy, healthy guy, in pretty good shape. And so we started having this discussion, and he was like, well, should I come fly to see you? And I said, well, we take care of a lot of destination patients. I'm happy to help you. We have like a partner for that who, arranges all the hotel and the transportation and whatever, which is great if that's, your speed. But a lot of people are going to say, okay, like, thanks for your opinion. That's really great. How can I find somebody closer to me? And so we started talking about this, right? And so we looked at his MRI and I said, listen, for, a patient like this, based on his unique risk factors, I said, we have a greater than 92% success rate with a single multi-level high-dose leukocyte pour PRP that's injected from a transforaminal approach with additional treatments of the ligaments and the muscles that surround the joint, basically, or the disc, right? And so he was like, okay, well, how do I find that person there? And obviously, if I know somebody in the
Mm-hmm.
territory, I'm going to say, go see this guy, right?
Of course.
Or girl, or
Mm.
man or female,
They, them.
whatever,
Sure. Yeah.
they,
Yeah.
them,
Yeah.
yeah.
Yeah. Yeah.
And so we started talking about like, well, how do I figure out who that person is? And I said, okay, well, first of all, they need to have expertise in image guidance, right? So they need to
Mm-hmm.
have done a lot of procedures, both with ultrasound and X-ray. And some people now are combining the two approaches for good reason, but who feel very confident doing both, right? So that was kind of like the floor.
Mm-hmm.
And then we started talking about, okay, well, like what types of grafts do they use? Do they do PRP? Do they do bone marrow? Do they do adipose? Why and why not? What's the volume of cases? Do they collect their outcomes data? So that was really big
That's
for
a big
me.
one.
So if I come
Yeah.
in the room and I say I've done, 678 of these cases, and every time we exceed 10 billion platelets, we typically have greater than 92% efficacy from a single procedure, people become very confident because you're like, okay, I'm not just referencing, a paper that got published. And
Yeah.
some papers are great, but some
Sure.
have flaws, right? So I think collecting outcomes data is really big because data doesn't lie, right? It's just like it's good or it's bad, and
Mm-hmm.
take it for yourself and make a decision.
Yeah.
And then quantification was the other big thing. So I said, if you go have a procedure like that, and I ask you, what was the dose? You should be able to answer that question. Right. And most, 99% of the patients that get procedures like this don't or can't. But for me, like I make it a really big deal to say, let me tell you why I'm so confident you're going to get better, because we measured your graft before and after we produced it.
Yeah.
And this is why you're going to do great, because it's X, whatever that number is.
Yeah.
Right. And then usually they leave and they go, oh, okay. And so that's in the back of their mind, right? And psychology obviously helps, right? To be
Yeah.
like, this is why we're confident.
Mhm.
And then the rest of the plan with how you're going to do your rehab, et cetera, also obviously is hugely important. But so those are the things I usually tell people to look for. I said, you need expertise in imaging, you need expertise in cell quantification and cell biology, and then you need to collect your outcomes data. And if you find somebody who's doing that, whether they're in academia or private practice,
Yeah.
they're holding everything to the highest standard, and then you can at least be confident that, they're going to give you a good recommendation.
So you need to make sure they have the experience, they have a clear process rationale, and they collect the outcomes that they can show proof of concept.
Good summary.
What I hear in that is that you don't want the new guy.
Well, I think, this is interesting because like when I was coming out of training, like I helped build a curriculum for our residency and teach them some stuff. And it was based on a model that was already out at Mayo Clinic. So we more or less just copied it and, maybe iterated on a little bit of it. There were already fellowships to do sports medicine. There were already fellowships to do spine or pain medicine. There was not at that time, or there was just starting to be the first fellowship program in how to do regenerative medicine for orthopedics, right? And now there's two. So there's one in Colorado and there's one in New York, and that's it. And you see it, whereas like in the 90s, like we were just starting to be able to use like X-ray or fluoroscopic guidance. That's when like all of a sudden this huge field of interventional spine like became a thing, right? Because we could see stuff and we could guide and direct needles in ways we couldn't do it before.
Yeah.
Right. So in my opinion, we're early on sort of in that curve for regenerative medicine. And I think the lack of adoption by insurance companies has certainly, halted a lot of the development of that. And a lot of times you see the people who are really committed at being great. We have talked to colleagues in Europe. We have talked to colleagues in South America. There's really good data coming out of South Korea. So it's a very international medical community, more so maybe than some other aspects of medicine. And to some extent that has to do with, requirements and restrictions by the FDA. And the FDA does a lot of things to keep people safe, which is
Hmm.
great. But sometimes that can be at the expense of innovation. But I think if you had access to the data and you have access to the people who, can prove their reputation
Hmm.
and you have the means to go anywhere, then you're going to seek that out. Right.
Yeah.
So I think it's been interesting to see how the field evolves, but
Hmm.
there are probably, a couple places in the country where if you train in a certain niche
Yeah.
of residency, like you get more exposure to regenerative medicine than you would
Sure.
otherwise. But it's still not common, right? So that was a
Hmm.
very long-winded way of answering. Don't trust the new guy. Um, but there are guys who are new and
Yeah.
they're working with an expert that become great,
Yeah.
right? And so that I think also matters, right? Medicine's very much a field where we stand on the shoulders of our predecessors,
Hmm.
and then ultimately it's up to us to pass it on, right?
Yeah.
So
Well, I think that's a beautiful cap to this first part where we've really dove into some of the essential elements that coaches need to understand about some of the alternatives inside of the medical industry that exist, where people generally speaking think about hospital, not hospital, right? Disease, not disease. Well, if they're not disease, then we just try to bridge that, and that requires a very sophisticated allied health professional, whether that's a nutrition coach, personal trainer, physical therapist, whatever, to get that person moving. So you're definitely going to want to make sure that you guys stay tuned for part 2 here, where we're going to dive in with some of the top interventions that in the regenerative medicine field are going to be things that are recommended and indicated for people that may be needing some of that stuff. So with that said, thank you for being here with the Beyond the Pump podcast, where we talk about the business of fitness and nutrition. Thank you so much, Dr. Turner, and we look forward to having you in part 2.
thanks. Looking forward to it.
All righty.